Leaders of nations, public health officials, and global institutions, history will judge you, not by your speeches, conferences, or promises, but by what you failed to stop when the warnings were already clear. Let your children as adults not ask you, what did you do to prevent the crisis that threatens our very existence? Be the leader like me who identified the problem, raised concerns, challenged institutions and the leaders in the UK, and suffered because I created Maya to prevent my daughter from suffering and dying before I did. People protest when jobs disappear, wages fall, industries collapse, or politics fail. Yet almost no one is preparing for the silent crisis that could take away their health, families, dignity, and even their lives. The spread of antimicrobial resistance and infection will be no respecter of position, wealth, status, or power. This is not about spreading fear. This is a biological reality. When those entrusted with responsibility ignore preventable suffering, they do not stand above the danger. They stand directly in its path. Dharma is not ritual. It is the duty to protect life before disaster occurs. The enemy will not destroy a society that forgets this truth, but through the silence of those who saw the danger, understood the warning, and yet chose comfort, careers, and prestige rather than the lives of other human beings. The epidemic in the Democratic Republic of Congo, caused by the Bundibugyo strain of Ebola, highlights a grave crisis in our global health security. Meanwhile, in Kerala, India, a serious Shigella outbreak continues to leave children hospitalized, highlighting the devastating impact of entrenched vulnerabilities. These pathogens work through completely different biological mechanisms. Ebola spreads through bodily fluids as a hemorrhagic viral fever, and Shigella as a bacterial infection causing widespread diarrhea. Yet both outbreaks share a common failure: our public health system's inability to control them effectively. This failure is not solely due to biological factors, yet it arises from systemic flaws, delayed symptom recognition, missed contact tracing, and slow reporting that structurally create blind spots that pathogens easily exploit. They defeat our defenses not because of biological weaknesses, but because of systemic gaps that allow outbreaks to grow unchecked. To prevent future disasters, we must understand how infectious diseases spread beyond local containment and turn into epidemics. Each outbreak begins with a single unknown carrier, what we'll call zero, who inadvertently starts an ongoing chain reaction. From this home, the disease spreads rapidly to 3 family members, then 10 clinic visitors, then 100 community members. The troubling truth is that by the time our health authorities issue an alert based on clinical diagnosis, the pathogen has already spread rapidly through complex networks. It is essential to improve our early warning systems and close these structural gaps. Only then can we gain control over infectious threats and protect vulnerable groups before it is too late. There is an invisible chain of contacts between the first symptoms at home and the first clinical diagnosis that bridges the pre-diagnostic gap. This chain relies entirely on human vectors operating under the radar of surveillance, asymptomatic family caregivers, local transportation drivers, and passing community contacts, all of which are active transmission mechanisms. These individuals contact fomites, physical objects such as bedsheets, specimen containers, and the surfaces of shared transit vehicles, which carry the disease from one place to another. Standard infection prevention measures struggle to break this chain because they are designed for known threats rather than unrecognized carriers moving freely through a community. Even in professional settings, manual hygiene has strict limits. The Department of Health and Human Services says that if a healthcare worker already has a dangerous organism on their hands, then yes, washing is a backup measure. Prevention has already failed in the clinical environment, where surface contamination acts as a persistent reservoir. Routine cleaning struggles to keep up with the constant influx of multi-drug-resistant organisms on bed rails and equipment. Relying solely on manual sanitation without identifying and isolating the source at the field level treats only the symptoms rather than addressing the root cause of transmission. There remains a widespread misconception that medical facilities serve as containment zones. In fact, we face a paradox in healthcare. Consider the physical activities of symptomatic patients. They leave the house, ride public transportation, and share breathing space with uninfected passengers. Upon arriving at the hospital, they sit in a crowded triage center or waiting area and shed large amounts of the pathogen while waiting for evaluation. As well as vulnerable individuals, field health workers, such as phlebotomists or social workers, face serious risks, especially without pre-triage data. They often move between infected homes and uninfected families, often without recognizing the danger, unknowingly carrying the pathogen. Without you, according to preliminary field-level data, standard medical response protocols often force infected patients into densely populated areas, thereby accelerating transmission. Their goal is to stop it, even if authorities successfully map the transmission network. Prevention depends on human compliance, which is consistently the weakest point. An outbreak response for hourly wage earners or low-income households. Failure to comply with strict quarantine orders carries devastating socioeconomic penalties, immediate job loss, and severe food insecurity. Housing instability, with its resulting severe psychological burden on isolated individuals, involves intense issues. These include community stigma, fear of being considered dangerous, and anxiety about managing symptoms alone. These accumulated pressures create an environment where prescribed treatment feels as devastating as the disease itself, leading to financial ruin and social isolation. Exposed contacts are economically incentivized to avoid them. Tracers often hide their symptoms or provide inaccurate histories. Public health policies mandating strict isolation will fail unless they also address the significant socioeconomic penalties imposed on patients. Breaking this cycle requires a shift from reactive clinical tracking to proactive community-based detection before symptoms appear. This requires deployable, decentralized technological interventions, especially devices. The Dr. Maya app and Prema kiosk are designed with one key function, capturing initial symptom reports directly at the home level, before the patient even tries to travel. They use simple, color-coded risk identification and multilingual education to overcome the confusion and fear-induced delays that prevent people from reporting illnesses. This approach advances community data collection, reduces behavioral resistance, and eliminates the delays that typically hinder public health surveillance when such technology is used. This creates an immediate early warning feedback loop. First, the user logs symptoms remotely. The system then provides local advice on isolation and testing the patient at home. This data is then shared with a public health center, where officials can monitor infection clusters in real time and map outbreaks before they reach clinics. With this intelligence, health departments can coordinate safe, targeted sample collection at the patient's home, protecting field workers and enabling clinics to serve as amplification points. This hub-and-spoke model breaks the chain of transmission, keeping the patient where they are and getting critical data to those who need it. For public health officials, the message is clear. Highly infectious pathogens will exploit every gap in preclinical field data. This technology offers a way to protect vulnerable populations without the stigma of abandonment or economic devastation associated with traditional isolation. Digital infrastructure must be deployed immediately for the next pandemic. Waiting for isolated clusters to appear guarantees that they will develop into regional disasters. Health departments, NGOs, and hospital administrators must work together to validate and deploy this system, creating an early warning network that protects communities. Scan the QR code and call him on WhatsApp to learn about Dr. Kadiyali Srivatsa's contributions to healthcare. Be a leader in literacy and public health, and be remembered as the person who implemented the system that revolutionized healthcare in the 21st century. Protect, prevent, and empower individuals to overcome fear and reclaim their free will. Let Dr. Maya AI and Prema Kiosk serve as an early warning system before fear spreads faster than the infection.